Thank you very much, Dana. That was a brilliant talk. So very pleased that you're able to join us to have some discussion now about the topics you were covering. So I think there's such a broad spectrum of issues that you exposed really in that talk. It's kind of where do we start? Let me just start with some expressions of appreciation from our audience. One person has made the comment that managing decisions with chronic illness can be so exhausting. Any ability to streamline is a game changer. And that's so true, isn't it? We sometimes talk about the disease condition in a kind of textbook way, but thinking about the anxiety, the pain, the stress, the fatigue, it's a good reminder, I think, of really what we're trying to achieve, why we're doing all these things.
Yeah, I think the decision-making fatigue involved in living with chronic diseases and people interacting with the healthcare system is just something that's not talked about and not looked about and understood until somebody is diagnosed themselves and they start facing with it. I think one of my colleagues, a patient researcher named Sarah Ragare, she did a really wonderful infographic that highlighted the number of hours she, as a person living with Parkinson's, does self-care and management of Parkinson's disease versus the maybe 1, 2, 3 hours she spends in the healthcare system interacting with her doctor in the course of a year. And it really starkly highlights that, 99 point something percent of the time, people are doing the work themselves, day in, day out, no breaks, no vacations, no days off. And I think that's just something that takes a lot of time and energy and just really isn't talked about. So when we think about the technology and we think about the opportunities, it's not simply the diagnosis or the treatment, but it's really this ability to impact all these other moments people are living with.
Yeah, thanks very much. And I think that that brings to mind the kind of, how can I say, the bigger issue here of how big a place the patient and the citizen has in the thinking about prioritization and policy around health and care. And it just struck me that, we have so much attention when we think about decision support, clinical decision support. We often cite cognitive overload, or we talk about clinician burnout. We don't have that same volume of discussion, I think, around patient cognitive overload and patient burnout. Would you comment on that?
Yeah, absolutely. And I think this is really where, when we talk about technology, we kind of assume for technology and treatments in healthcare that if we give somebody a tool, they're going to turn it on and use it for the rest of their life or the rest of their dealing with that condition, which may or may not be true. In the case of diabetes, there's times where I felt burnout. I've now had this condition for almost 21 years. And there's times where I just want to live my life and do less with diabetes. And I would like to be more hands off. And sometimes I accept slightly different outcomes in terms of short-term glucose levels in response to that. And other times I want different outcomes and I'm willing to do more work when I'm less burnout or I have more time on my hands. But I think the healthcare system and the way we talk about these tools and technology kind of assumes that whatever level of outcomes I want, that's exactly the trade-off that I'm going to choose for life and permanently. That's a one-time decision of this work input, this output that we're going to get. And so we've got to come up with tools that are able to be increased, decreased, turn on and off to better match the needs in the short and the long term of people living with these conditions. And again, kind of just the life cycles people go through, right? When people have children, I think this is something that's really common. They, stop sleeping because the children are waking them up at night. They're dealing with all this stuff. And so the amount of time and energy they can spend on work and other activities and their own self-care drastically changes. And that's one of the best analogies, even as a person without children, that I understand that other people maybe understand. That's kind of like what living with a chronic illness is, except for with the chronic illness, it doesn't go away. It doesn't grow up. Where your child might move to the stage of sleeping through the night, things get better, things get different as the child grows up. With the chronic illness, it doesn't. But that same idea of your time, your bandwidth, your energy, what you're doing on a day-to-day basis drastically changes. We don't really have that flexibility built into technology and healthcare systems yet. And I think that's where we ultimately need to go, where technology can be that flexible. These treatments, this technology is supportive and can flex up and down as people need it. And truly based on what the person, the patient, the caregiver needs at that time, and not something prescriptive from the healthcare system about what they should be doing.
Yeah, no, that's a very good point. So in your mention about prescriptive from the healthcare system, that brings to mind another question that's arisen around, have you encountered any clinician resistance to this concept of patient-led, patient-driven innovation in the delivery of these technologies?
Personally, in my healthcare encounters, no. My providers have been either kind of neutral, didn't care, or supportive of what I was doing. There are other patients who have, built their own solutions, whether they're related to diabetes or other spaces, and have had resistance from their clinicians. In some case, it's fear and uncertainty of this is something outside the normal, and they're concerned about liability and what's going to happen to them as providers if they quote unquote permit a patient to do this. What does that mean for them? And will they be held legally liable for that? And obviously across the world, different countries have different legal frameworks and different cultures for healthcare providers. And that and personality of the provider can play a role in how a provider kind of responds when a patient comes up to them and says, hey, I built this tool, or I found this tool, I'm using this tool, here's what it's doing for me. But I think we're going to see more of that, especially as we have these LLM tools that really enable people without historically, training in data science, data analysis, to be able to do really powerful, really thorough analyses of their data, or use these tools to build other tools and solutions to help them manage on a day-to-day basis. What I did 8 years ago sounded so wild, so out there, so novel, so different. But I'm probably now one of 100 stories, and I bet in the next couple of years, it'll be one of 1,000 or more than that stories of people building tools that really work for them. Whether or not they scale to more than one person or more than a couple of people, it doesn't matter. But clinicians, I think, need to be prepared to meet patients where they are and really listen to the needs that patients are describing. Patients don't do this for fun. Right? I'd love to have more time to do other things in my life, not necessarily have to build these tools, but I build these tools because there's a need that's not being met. And I think the best patient-provider conversations happen when clinicians kind of stop and listen and ask questions about what is the need, are there solutions, and recognizing that it's okay for patients to do something on their own. That's always been like self-care, self-management has always been a big part of chronic disease management. And this is just another kind of more modern aspect of it. But I do think clinicians need to be flexible and willing to have conversations and not try to shut a patient down or tell them just without listening that they can't do something, because I think that harms the relationship. In some cases, a patient may be able to go find a different doctor. In other places, they can't. And so that patient may decide that they can't talk openly and honestly with their provider about their goals, their needs, and what they're doing. And I think that ultimately can be dangerous. So I think there's a lot of good in these conversations, but I think how the provider reacts really sets the tone for future conversations as well with the patient.
Yeah, sure. And I think it struck me that in your presentation, you kind of talked through really the whole life cycle of knowledge, right? From clinical research that discovers new knowledge through to, how we then prioritize which of that needs to go into guidelines, and then how we implement those guidelines into technology and other software. Going back to the beginning of the pipeline, the research that generates new knowledge, or the quality improvement initiatives that generate local knowledge around healthcare systems, do you feel at that end, the beginning of the pipeline, do you think there's enough attention paid to the patient and citizen voice?
No.
Well, that was a nice easy answer.
Short answer is no. The longer answer is, I think a lot of times clinicians or researchers, whether they're clinical or not, have an idea about what to study. But I think there's many cases where historically what has been studied is not what actually matters to the patient. Whether you're studying the endpoints and the outcomes and the measurements are of things that don't actually matter to the patients. And that ultimately means what does matter to the patient isn't measured, isn't tracked, isn't used. And the reason that matters is because when this research rolls out and when things come to market, if a patient has an experience and it's not documented in the literature because it's not been measured, they don't know whether their experience is typical or not, whether they're an outlier or not, and whether it means that they are getting the ideal outcome that they can get with this treatment, this drug, this therapy, whatever it is. And in the case of EPI, we see it quite a lot, where most of the research is on safety and efficacy of the enzyme therapy. There is minimal to none. I think there's maybe 2 papers that actually talk about titrating and actually fully adjusting for symptoms. but it's in such a subpopulation, it can't translate to the whole population. And so even though the point of enzyme therapy is that you're supposed to be reducing symptoms, we have no studies at this huge population that actually looks at what on average for this population is required to reduce symptoms, or can symptoms be reduced. And there's just these huge gaps left behind. And that's also why I think patients aren't taking enough. The feedback to the doctors is that this doesn't work. And so then in turn, doctors often don't even prescribe it, even when patients meet the diagnostic criteria, because the doctors believe that the treatment doesn't work to resolve symptoms. So what's the point? And so then more patients go untreated. And so it kind of just creates this vicious cycle down term. So going back to the question of, are patients involved enough at the start of clinical research? My short answer is no. And the longer answer is, we need to absolutely be thinking of who even decides what should be researched, what the priorities are. We've seen an increasing push to add patients to researchers as patient partners on research projects, which is a step, but it's not the answer, I think, because a lot of times the idea is formed, the grant is written, and then a patient is invited to participate. But at the stage where they can't recommend endpoints, they can't change the protocol to make it a study that's actually going to answer the most important questions to the patient population. So we truly need to keep taking steps backwards and involve patients at the very early stage of what is important to people, where are the gaps, what can we study, what is meaningful to study, and then how do we design the research to do that? And that's where I think we need a huge injection of patients and caregivers, because that's where we'll start to fill the gaps.
And that relates to one of the questions that's been posted. Somebody said that exactly that point, that we often miss the disability chronic illness perspective in medicine, because the path towards becoming a health sciences professional is so inaccessible. How do we get more patient leaders and perspectives in healthcare and health research? How would you respond to that?
Oh, I think it's a fabulous question. I don't have the answer. I think we need a lot of work in this space. But speaking of disability and chronic illnesses too, something else that I've observed in the literature is a lot of times we exclude these populations from the research. So an example of EPI, again, because this is where I've spent time reading 600 articles lately, a lot of the studies that are done exclude kind of the majority of the population. And so if you take, somebody who's looking at some study, they exclude people with diabetes, even though people with diabetes are kind of 10% of the general population. They're hugely prevalent in the population of EPI, but because they're excluded from the study, they're not presented and they're not seen as a subgroup. And so there, until recently, was relatively little attention and awareness that people with diabetes often do get EPI. And again, when somebody with the diabetes presents with GI symptoms, they're not screened for EPI because there's no awareness among gastroenterologists or diabetes specialists that this is a condition of concern. So I think we need to do two things, which is I agree with the commenter that we need to get more people with disabilities and chronic illnesses into these traditional spaces. And that maybe starts with thinking about, how do we train people? What does expertise look like? Who gets funded? Lots of stuff there to be done. But I also think we need to look at, if you're designing a study protocol and you're trying to exclude people because they have conditions and it might make your data a little bit messy, think about the downstream effects of excluding these people from your studies and how that's going to impact future care. And I think we need to do more to include these populations in our studies, because there's almost huge groups of studies that need to be completely redone to address people with disabilities and these chronic diseases that are left out, because it also impacts, these people won't get prescriptions because they're told that there's no indication for them on the drug label because it's not been studied in people with diabetes or people with disabilities. And instead of prescribing it off label, providers sometimes will be concerned, afraid, and resistant to prescribing it, even if there's no indication that it won't work for them or that it would cause harm. So there's a lot of these downstream impacts and almost harms from the way we create really narrow inclusion criteria and exclude a lot of people from the research. And so when we think about solutions and expanding things up, it's again, go back to that very beginning of how we design the research. I think that's a really critical point that we don't pay enough attention to.
Yeah, no, thank you. And just to pick up on this theme of how do we get more patients and citizens involved, I should declare an interest that the way I got to know Dana was through an initiative through BMJ Health and Care Informatics to get patients, citizens and carers involved in peer reviews and indeed writing articles. And not just that, but similarly, what role do you think those kind of initiatives play in reaching out to build this community?
Well, I think it can be really powerful because having patients and curers doing peer review gives them an opportunity to have individual interactions through anonymous peer review with different researchers and clinicians who maybe have never been exposed to this idea of patient partners in research, and to say, hey, look, I recognize your study is done. Here's some patient perspective, the lived experience perspective that you might want to include in your paper, or, add to the discussion, or whatever the feedback is. And also, please consider doing this in the future, like from the design of your future studies, involve patient care partners. And it's a very small, long-term approach, but those little breadcrumbs of sprinkling people's feedback throughout and exposing new clinicians and researchers and authors to this idea of patient partnership and showing them that patients have really valuable feedback. I just think that's another long-term strategy. It's small, but it can be really, really effective in reaching a lot of people who aren't in these spaces, aren't coming to these conferences, aren't aware that patients and carers can give really powerful input and improve studies for the better.
Sure. And to take up one very specific thing, again, something which is often featured as a challenge for clinical decision support is around multimorbidity. Because as you said, in clinical studies, typically we exclude the multimorbidities because it gets too complicated. But then we write the guidelines and then we have to somehow combine them again that becomes even more challenging when we're trying to do that computably. How do you feel the patient lived experience might help to kind of build an understanding around multimorbidity and how we need to be thinking about the combination and the kind of multiplication of factors involved when there is multimorbidity or polypharmacy?
Yeah, I don't have a good answer to that, but I'm really hoping that with LLMs really empowering not only patients, but also clinicians and researchers to do deeper multivariable analyses that maybe were hard before, or they felt like were out of their skill set. I'm hoping this computational power gives us more ways to break down and look at the correlations among variables, and gives us new opportunities to figure out, okay, we've got these multimorbidities. What does this mean? Can we discern a difference for these populations or not? And generally give us language to move forward with not excluding people and saying, this wasn't tested in this population, but there's no indication for harm, and making stronger statements about, clarifying based on the knowledge of the literature that these people were excluded, but it doesn't mean that there is evidence of harm in the literature based on these research studies. So again, I think there's a lot to be done. Yeah. I don't have the answer to that, but I feel like these are the questions we need to be talking about and thinking about how we move forward, and thinking not just about incremental steps, but thinking like, let's wipe the slate completely and rethink. If we were starting from scratch and there was no medical literature, how would we design these studies with the tools that we have now and what we know now about this? And then also recognize that most patients, if they have one autoimmune condition, chances are they probably have another. They probably have multiple conditions, where I think historically, a lot of those early studies looked at people with one condition and assumed they had one condition and that was it. And there was no interaction or interplay, across conditions or with their bodies or with medications. But the reality is, unfortunately, my personal experience has been this as well, is that I now have 4 autoimmune conditions over the course of 20 years. They don't really interplay with each other, but most of the studies I'm excluded from because my first diagnosis was type 1 diabetes, an autoimmune condition. And so nobody wants to study people with diabetes. We're always excluded. But then you think about why people were excluded 20, 50 years ago from these studies. It was because the outcomes of people with diabetes were drastically different, because we didn't have blood glucose meters, let alone CGMs, let alone insulin pumps. Now we have automated insulin delivery systems. The outcomes with people with diabetes are drastically different. And so we also have to check kind of our assumptions about why things have been done the way they are and whether those things are still true. So why we excluded people with diabetes 50 years ago and then 20 years ago, that didn't quite hold up. And then definitely now, when we have most people on this modern insulin delivery technology or multiple daily injections, just the lived experience of people with diabetes is a world apart from what it was 50 years ago. And therefore, the way we do research with people with diabetes and other topics, people with diabetes shouldn't necessarily be excluded from that. So I think we really have to rethink, what are these assumptions about the way we've excluded or included populations in our research? And I think once we start to make those shifts and really reevaluate kind of what we know and whether that's still true based on modern information and modern technologies, I think we're going to start to make even bigger leaps in knowledge and really start to fill some of these gaps.
That's great, thank you. And maybe just one final point. We're often talking about healthcare, so much we need to be thinking about prevention. And, you know, we're thinking about social determinants of health and other factors which are, you know, largely causal here. Do you feel that greater involvement of patient and citizen voice could help in addressing how we manage things like social determinants and other risk factors in getting more effective at prevention?
I do. And I think it involves getting a greater number of patients and people with lived experience from a number of diverse perspectives. You know, I'm always very clear. I do not represent everybody with diabetes. I probably represent personally very few people with diabetes. I can speak to my experience, but I recognize that my lived experience does not universally match everybody's else. And I'm clear to say that and to limit that and to recommend bringing in other people who have different lived experiences, different ethnicity, different gender, different lived experience, and to bring that into part of the conversation. And when we talk about prevention and social determinants of health, this is even more important to find ways to pay and bring these people into the conversation because they have the power to lift up their community, lift up their lived perspective, and really powerfully reach people who've not been reached. But again, I think we need to widen the number of people and the types of people that we bring into these conversations. I think it absolutely is an answer to help with some of these things, but we need to think more broadly and not just go with, well, we worked with this person before, so we're going to use them again, and really look at, okay, how do we reach new communities and bring them in and support them and make it possible for them to equitably participate, which often includes paying people for their time. And that's something I think as healthcare professionals, and I say this as somebody who's not a professional clinician, but has worked in the healthcare space, you know, when we sit there from our day job, we don't think about other people coming to help in the healthcare system. That's not their day job. We should absolutely be paying them for their time because they have to take time off of their jobs and from their families and from their lives. And we should be paying them a minimum for their time, let alone their very powerful expertise. And that's something that I don't see done to the level that I think we should be doing. And I think that also will get more people to be able to contribute equitably when we actually pay them so that they can show up and they can, you know, help serve their communities in that way.
That's great. Thank you, Dana. So I think that's been a really great opportunity for us to reflect on the role of the patient, the citizen, the carer in really the whole of the computable knowledge life cycle. So I hope that's given our audience plenty of food for thought, and we look forward to the progress of your work and looking forward to see what comes out of our work with BMJ. And thank you again for joining us today. It's been a really brilliant talk. Thank you.
Thank you for having me.